now, please. Okay, all right. So here we go. So I think the first thing is what I'm going to overview over here is adhesive capsulitis, the usual findings on radiographs and MRI, some common mimics, some easily missed findings of other causes of significant shoulder pain that could be mistaken for adhesive capsulitis, and finally a word on image-guided injections. I think everyone has mentioned previously that usually with patients who have adhesive capsulitis, you should have a normal X-ray. I think the important thing over here is for most people to realize, and we have seen this very often, where people get a single view of the shoulder. And it's important for people to realize that there are multiple different views. You should be aware of which ones you want. And based on the pathology you're looking for, sort of take a call as to which one you want. So this is a normal AP view of the shoulder, where here you can see there's actually the radiographic beam is parallel to the glenoid. And so you can see the glenoid sort of in profile nicely, and you can see the joint space, as opposed to a regular AP view where you'll see overlap between the glenoid and the humeral head. And most places you end up seeing the latter instead of the former. Is one view enough? I mean, this is a classic example and not an uncommon one, where you can see here the X-ray looks relatively normal, and then when you look at an externally rotated view on the same one, you can see that there is a very significant calcification here in the supraspinatus. So one view is often like no view, and so before you call something as being abnormal, it's recommended that you get an additional view, at least to look for other abnormalities. Now, as far as the MRI findings go, because it's a capsular process, the first thing that we end up looking at is on the sagittal images, you can look at the rotator interval. So here you see the supraspinatus, the subscapularis, the biceps in between, and then the coracohumeral and superior glenohumeral ligaments. And that area here you can see has got thickened, as opposed to this case here, where you can see that there is bright signal around it, which is basically fat. So this is someone with adhesive capsulitis, or at least early capsular inflammation in that area. The second thing you can see is the inferior capsule, like over here. And you can notice on the non-fat suppressed image how nicely you can see the capsule as compared to the fat suppressed image, because it contrasts nicely with the adjacent fat. So you can tell the thickness of the capsule, and then the fat suppressed image, which is the black image, helps to tell you whether there's edema in the capsule. So increasing edema is a sign of adhesive capsulitis and increasing thickening. As the process progresses, you can see far more intense scarring in that rotator interval and the inferior capsular thickening. Now, it's important also to realize that we see capsular thickening and rotator interval edema in not just adhesive capsulitis. There's a whole host of other conditions when this happens. So if you just see this capsular thickening and edema, don't jump to adhesive capsulitis every time. There are situations such as this where you can see patients who have had either anterior instability, where you can see capsular edema and thickening. Then look carefully for the Hill-Sachs and the anterior labrum. You have situations where patients have posterior instability and they have posterior capsular thickening and edema in that posterior capsule, as well as rotator interval scarring, and those can be mistaken for this. Take, for example, this case who has insidious worsening shoulder pain. You can see edema within the rotator interval. You can see the inferior capsule looking thickened over here, and you can see it thickened here with edema. And one would be inclined to say this is adhesive capsulitis. But what you also see is extensive subacromial bursitis in this patient. And this is sort of unusual for somebody with adhesive capsulitis. And this is somebody who has an inflammatory arthropathy. So early inflammatory changes also begin within the capsule. And these things can be picked up very nicely on MRI. But one does need to be alert about the other findings. Moving on to, this is a more chronic case where you have rheumatoid changes that are a little more chronic, and I'll just skip by this in the interest of time. Here's a patient with shoulder pain. The radiographs are rather insidious, and this is your normal picture that you will see in somebody who comes in with adhesive capsulitis. And yet, one is often inclined to just go ahead and treat these as adhesive capsulitis. I think adhesive capsulitis is a diagnosis of exclusion. I think in many of them, we're now finding very significant other abnormalities. And this is a younger patient in whom we actually found this this sort of bright, this cortical-based lesion with a lot of edema around it, which turned out to be an osteoma. Here's another person who had a trivial injury, came back with a stiff shoulder, and actually ended up having a greater tuberosity fracture, which you picked up on MR, which didn't show up on the X-ray. Here's another patient who is sort of a bench-pressing, bodybuilding type, who showed up with shoulder pain with a normal X-ray, and here you can see distal clavicular edema, and you have a distal clavicular stress reaction, which is a common thing in these people, which will produce significant restriction of movement. And then here's a patient which, you could, if you didn't know this any better, you could say that this person has essentially what looks like a rotator cuff tear with edema here, and there's a split in the rotator cuff and there's subacromial bursitis. Whereas this is actually a globular focus of calcification, which has the exact same signal as the adjacent tendon, and this can be easily mistaken. So if you had that embarrassing X-ray from the beginning where you got only one view, you had this MRI which showed this subscapular, subacromial bursal fluid and the bone edema, you might say this is cuff tendinopathy, whereas actually all you're dealing with is a calcific tendinitis. So acute calcific tendinitis. Some small, subtle bursal-sided or pasta and antipasta lesions, as Dr. Narvikar likes to call them, are things that can produce pretty intense painful symptoms and can be missed quite easily on a poorly done MR. So I think it's important to look for those. So if we were to summarize the imaging findings for this, what we'll find is adhesive capsulitis is often as clinically a diagnosis of exclusion. Normal radiographs are a good start point, but make sure you have taken appropriate views to exclude radiographic abnormalities and don't get embarrassed otherwise. Inferior capsular thickening, rotator interval edema are classic findings that we see with adhesive capsulitis, but I think it's important to remember that there are other conditions that can produce this, and therefore one should look out carefully for those other conditions like instabilities, especially, and early inflammatory arthropathies. When you have a normal radiograph and you're labeling someone as adhesive capsulitis, just remember there could be some other causes. So if you miss something in your history, or if something is not very clear in the history, it may be helpful to consider an MRI in some cases, especially when it doesn't fit. It's a non-diabetic young patient. Maybe you consider doing something else to see what's going on with these patients. Image-guided injections is something that we have always sort of pushed for as radiologists. There is enough data now from even the orthopedic literature as to how these are far more accurate, less painful, and produce better outcomes. In terms of intra-articular injections, early stages of adhesive capsulitis tend to do better with intra-articular injections. Later stages may not produce that much of a difference. The issue of hydrodistension is one that is debatable, and I'll leave that to everybody because there's data to support either side of the argument. Hyaluronic acid is something that just adds cost but hasn't been shown to significantly change the outcomes from this. And this is just to give you a sense for, sort of when we do intra-articular injections, what we can see. So here's somebody who we did here's the glenoid, the labrum, the humeral head. And what you'll see over here is you can see the needle, and you can see it very clearly going into the joint. It's right inside the joint over there, and you can see us distending the joint very nicely, and you're very confirmed and convinced that you're intra-articular. And surgical studies have shown that ultrasound-guided injections are far more accurate than freehand injections when it comes to injecting even a large joint like the glenohumeral joint. Same is true for the biceps tendon sheath, and sometimes in patients where you want to get stuff into the rotator interval, one could do a high biceps tendon sheath injection. Again, something we can see really nicely on an ultrasound examination. And finally, subacromial bursal injections also, where we're very accurate. And this just to give you an idea of how cleanly we can get into the subacromial bursa and how nicely you can see yourself distending the bursa and the degree of satisfaction that you have that you're exactly in the right spot that you want to be. So I'll stop with that, and we can take any questions at the end.